I would like to thank the scientific committee for the privilege to present a vaginal implant study, self-retaining support implant for the treatment of advanced pelvic organ prolapse, long-term follow-up in the time of anti-mesh regulations. Review of the literature provides a good evidence that anchoring techniques which accompanies the placement of vaginal implants are a major factor in the occurrence of vaginal mesh complications. In order to provide the benefits of vaginal implants and while eliminating the complications of such mesh implants, we came up with a new concept involving an anchorless implant that we developed. The hypothesis was that the SRS, which is a self-retaining support implant with no anchoring techniques, will eliminate the complications associated with anchored mesh. This is a prospective international multi-center studies involving 6 surgeons in 4 medical centers. Patients with anterior compartment, at least second-degree prolapse, were recruited, and patients with previous mesh surgery were excluded. Follow-up included objective outcome using the POPQ exam and subjective outcome using a validated quality of life questionnaire, the PFDI-20. The implant is comprised of an ultralight polypropylene mesh, 16 grams per meter square, stretched and retained in place by a U-shaped solid structure. The device is inserted between the bladder and the vaginal mucosa, with the lateral arms following the anatomy of the cytic walls. No other anchoring techniques are required. 70 women underwent transvaginal repair of anterior and apical prolapse compartment using the anchorless implant. First patients were operated in September of 2014, and as of August 2019, the following follow-up mean was 27.7 months. We had no intraoperative or immediate post-op device-related complications. We had 1 case of frame erosion 8 months after the surgery, and 1 case of stress urinary incontinence de novo, which required mid-urethral sling. We had no chronic pain or no mesh erosions. 1 case had repeat surgery for symptomatic rectocele 6 months after the SRS implant. Objective results presented by the POPQ measurements before and after surgery revealed 81% at stage 0 and 12.8% at stage 1, accumulating to 94.3% anatomical success rate. Only 1 patient had anatomical recurrence with point C at 1 centimeter, and all second-degree anatomical failures were measured not lower than -1 centimeter. Subjective outcome reveals a significant change in the PFDI score in the domain of the prolapse and the urine. And based on question number 3 of the PFDI-20, we reached 98.6% subjective success rate. In conclusion, surgical reconstruction of anterior and apical vaginal compartments using the SRS implants provide high subjective and anatomical cure rate at long-term follow-up with no intraoperative or immediate post-op complications. Thank you.
Could you please tell us what is the material that the frame is made of?
The material is it's a polymer. It's a plastic polymer. It's biocompatible. It's called PEEK, P-E-E-K, and it's used in other implants in the body.
Do you ever have to plicate the pubocervical fascia, or do you just put the implant into?
The idea is to imitate the pubocervical fascia. So practically, it's the anatomy of the pubocervical fascia that we're trying to simulate.
Yeah. So you never plicate?
We don't plicate. It's actually kind of a new fascia that we install in place.
And how many of your patients were primary cases, and how many were secondary cases?
I will say about 50-50.
So would you recommend this for a primary case?
I think you need to select the cases. I don't think that all patients with prolapse
No.
deserve a mesh implant. But definitely in cases that you think either it's a repeat or they have any risk factors that will increase their chance for failure, then I think it should be even a primary case.
Did you investigate sexuality in these patients after the operation? How
Absolutely.
many? Yeah.
We had about 30% of the patients that answered the PISQ-12 questionnaire. You know, the intimacy of the questionnaire, sometimes you get less cooperation from the patients. But as far as the 30% that did answer, we did not see any new dyspareunia, and there was no decrease in sexually score from the PISQ-12. Thank you very much.